Thank you very much to the organizers for having us. So I'll present a case of a transcaval TAVR as an alternative access. So we had a 73-year-old smoker with no known drug allergies who had the following substrate: fairly typical hypertension, hyperlipidemia, PAD, had bilateral SFA stenting, and a fem-pop atherectomy of the perineal as well. He has COPD, and after a bout of COVID in January of 2021, he was oxygen dependent until most of this summer, and finally was weaned to just nocturnal oxygen. Also asbestosis, lung cancer, and a lobectomy, and then a recent admission only a month prior with a cecal pneumoperitoneum that was managed non-operatively in addition to recurrent C. diff. So he was referred for TAVR in the setting of paradoxical low flow, low gradient AS with a preserved DF. And we do a lot of CT calcium scores on most of our TAVRs as an adjunct to classify severity or re-stratify severity. You can see those gradients there with a mean of 24. And then he has a fairly standard list of optimized medical therapy. So in terms of our decision making, we look at all of our own CTs and make all of our own measurements. Given his frailty, his pectus excavatum, his oxygen requirement, and severe COPD and recent medical admissions, his STS score is gross underestimate of risk. And given these femorals, we were pretty uncomfortable with his stenting and the circumferentiality of the calcium and the size that we wouldn't be able to get an E-sheath up there without a likely major vascular complication. So we do all of these under general anesthesia, although I know that there's some move towards trying to do these more under conscious sedation. And for us, logistically, carotid is less easily attainable due to the availability of the hybrid OR, where we would do that procedure with our cardiac surgeons. And so we have opted towards more transcaval. In addition, this gentleman was a relatively smaller gentleman where his carotids were not extremely large. The risk of ischemia was there as well if we damage the carotid. And so with this, we have measurements here for an area of 534. So we chose an Edwards 26 for him. The sinuses are pretty large. His coronary heights and his sinus STJ heights are fair. And then we do our transcaval planning using the endovascular program in Vitria, which is the program that we've chosen. And so here we get an angle towards looking at the IVC and the aorta below the renals, clearly above the bifurcation, where there's minimal calcification. And I think it looks a little bit washed out here, but there's a little bit of a nodule that you can see in the leftmost panel, just beneath where we want the centrality of our coaxial puncture in R9. And that, in that view, I'll show you in the next slide what our arterial access with a gooseneck snare and the astato in the vein coming through a renal guide. Piggybacked inside that is a fine cross and then a navicross, kind of mother-daughter, granddaughter to get across. And then you have here a simulated aortic DSA of what it should look like when we're in our AP view. And then you can see what vertebrae we're using as a guide for puncture. And this gentleman had a kyphoplasty, so it was a nice landmark for us. So here you see on the left, we have our femoral anatomy, which is quite tortuous and hostile for us. And then we have after we get our arterial access and venous access, we put an 8 French sheath. Inside of that, in the vein, is our guide. And then in that, we have navicross, fine cross, and astato 20, which is shaved off in the back so you can electrify and puncture across when you burn. And then you have the gooseneck snare, which here the size of the aorta was about 16 or so millimeters, and we chose a 15. In retrospect, we could have gone with a 20, so a little bit larger of an area to shoot for. And in our R9 view, we want to see that the gooseneck snare is in AP direction, completely in a projection where it's thin. And then we switch to our extreme L view in orthogonal view, and we want to see that that astato is in the center of that, as the center of that lasso effectively. So now that we've confirmed an optimal position, we're abutting the intersection of the IVC and the aorta. We then cine, burn, and push across. And then you'll see that after our aortogram here in the last. So initially it doesn't cross, and then it crosses. And then we snare that, we pull that up into the ascending aorta, and then fine cross across. And then we take our fine cross out, and our navicross wouldn't go across over the fine cross. So we ended up ballooning with a compliant balloon to make room for the navicross to make it away. And then we basically take that navicross all the way up, exchange out for a stiff wire, a Lunderquist here, and put our E-sheath in. And then it becomes like a standard TAVR where we're putting in our valve, and then we do a little bit of a post-dilation with 1 extra cc. We went a little conservative because of the frailty here. And we had a little bit of a PVL, as you'll see on the next slide. So there's our post-dil. You see a little bit of a release. And then we routinely take an aortogram as long as there's no renal dysfunction. And the coronaries fill. There's not a tremendous amount of AI visible here. With our TTE, right after the first deployment at nominal, there's at least a mild to moderate leak. And with 1 extra cc of ballooning, where there was a bit of constraint and the pressure, the tactile feel of post-ballooning was a bit resistant, we were left with a mild PVL where we were satisfied in this relatively frail elder gentleman with a lot of comorbidities. So at this point, one of the critical points of the procedure is the gear removal. And so we get a buddy wire across with an 014 wire. We use a Spartacore, so something relatively stiff and like a rail for us. And then we end up getting our 035 up and have an Agilis ready with a cable and our PDA occluder, which we tend to use an 810 occluder. So once that's in, it crosses, the E-sheath comes all the way back past the aortotomy and the IVC venotomy, well beyond, because if you still obstruct the venotomy, you're just going to start leaking blood from the aorta directly into the retroperitoneal space, which is likely going to be catastrophic, or not likely, it will definitely be catastrophic. So the key is to pull the E-sheath back far enough into the IVC so that you have room, and then that's once you've gotten your Agilis across with the PDA occluder attached, and you have your buddy wire in case you need to go back. Expose it, and then tuck it back up, deploy, and then do an aortogram. And then if you like what you see, you can always get away with ballooning afterward in the aorta and take your buddy wire out. So here we saw suggestion without DSA of a little bit of a leak. So we came back. We always go up with a balloon that's sized to the aorta or slightly smaller and kind of push up the PDA occluder. And then after that, we saw post-deployment DSA, and I apologize, this plays very quickly, but you can see there that there's clearly quite a big leak. And this is because what I didn't show you is that in the initial attempts to cross, we tried a couple of times the Estado, and I think we ended up in the wall intramurally of the aorta and may have gone around into the retroperitoneal space. And so with this, we ended up ballooning after some protamine with a 16x40 Atlas and had to upsize our arterial access to an 8 French. And after several rounds of ballooning, we ended up with a post-DSA as follows. So you can see that leak is no longer there. You can see a lumbar coming through. So we spent a lot of time looking at this and did a couple of DSAs in between the repeat balloonings to make absolutely darn certain that we were not leaving anything there. And a little bit confusing with him was he had a pneumon peritoneum, so he had a very large belly after the fact, which everybody was quite concerned about. But he ended up going home the next day, and residual gradients were only 4 for mean gradient after he was kind of weaned and went upstairs and was discharged the following day. And he's doing really well. So with that, I'd be happy to take any questions. Thank you very, very much for organizing this outstanding conference.
Thank you. Any questions from anyone, from the judges? Please grade your judging. I guess the one question was, did you guys consider using the shock wave or some way to find your way up the femoral artery?
I think for him, we were kind of concerned with the right side because of the tortuosity. So even if we were to get a shock wave, when we were pushing our 7 French sheath, the tortuosity caused a lot of bending in that iliac. And so we were very concerned that if we shock waved and got a larger lumen, that we would be with a possible complication of an iliac rupture. And on the left side, there's a lot of diffuse disease with 1 focal stenosis that we just didn't want to add additional stenting to the femorals. And in our experience, we've gotten a little bit more away from using shockwave and going to transcaval because in our hands we've had fewer complications, knock on wood, for the moment.
Thank you so much. Thank you for
you.
bringing us your case.
Thank you.
Fantastic job. Thank you.